Good day, and welcome to what is always an exciting session at ISICEM, the Pro-Con debates. My name is Neil Ferguson from the University of Toronto, and today I have the pleasure of moderating what's sure to be a lively debate between two key thought leaders in critical care and mechanical ventilation, M.Amato and L.Gattinoni. Today we're going to talk about the future of clinical trials of PEEP, and M.Amato, who's Professor of Intensive Care Medicine at the University of Sao Paulo, gets to go first, defending the pro position that there is indeed hope. Marcelo, you've got 10 minutes to tell us why, and we'll hear the con from Dr. Gattinoni, followed by some rebuttal and time for questions. Over to you, Marcelo.
Thank you, Neil. So is there any hope for high PEEP trials? There is no relevant conflict of interest for this presentation. So my argument is going to be that the open lung approach is still alive. And there is this important question if the recent mechanical ventilation trials are contradicting lung physiology. And my answer is going to be no. The rationale and the physiology of the open lung is still alive and consistent. And then my main argument is going to be that there is a differentiation between a wrong concept and wrong methodology. For instance, we have had many problems with the clinical trials. One of them is the feeble efficacy of the open lung because of the bad PEEP choices and a negligible reduction in driving pressures. Then we have the problem of patient selection, and we know a little bit better about recruiters versus non-recruiters in terms of patient. And then a very important topic, the blurring of the previous benefit during the controlled mechanical ventilation, which is occurring because of the assisted phase, which is a long phase during mechanical ventilation. And we have detected many problems with desynchrony and breath stacking, and something new, excessive muscle effort, especially expiratory muscle effort. So where we are, we have 3 recent negative randomized clinical trials, all of them with severe patients with a very high PF ratio, very low PF ratio at entry, so severe patients, reasonable number of patients, but all of them with negative results. Even worse, in the ART trial, the treatment arm was significantly worse. So it's very hard to keep a position in this debate with this amount of evidence. In the background of this, we have 3 previous trials by the year 2009, all of them testing a kind of blind increase in PEEP, and all of them with negative results, non-significant results, and considered separated. So the general perspective is very depressive. And this is why when we look at PEEP FiO2 table, and this is the combinations of the low PEEP FiO2 table of the ARDSNet, this is the high, this is what people is doing around the world. So they are using even less PEEP and suggested by low PEEP FiO2 table of the ARDSNet. However, if you look carefully at the literature, you still find some hints that the open lung can have some rationale. For instance, in this paper published by our group, in the same year of the ART trial, we have randomized 320 patients with ARDS. It's a very specific population because it's post-operative cardiac surgery, but selecting the ones with very severe lung problems and hypoxemic respiratory failure. And they used a moderate PEEP, a little bit higher than previously, that the conventional in the institutional was 8, a recruiting maneuver of 45. And we follow very carefully all the patients. We had very good bedside monitoring with EIT. We could show that we could decrease the length of stay. This was significant, 2 or 3 days less in an average stay of 10 days, a shorter length of stay in the ICU also. And more importantly, we had very important improvements in physiological function of the lung. So the patients in the postoperative needed much less oxygen, and also they had less pulmonary complications. In the lab, we have been doing lots of studies for long-term studies. We have been using the open lung approach, and we have been able to decrease the driving pressure, and we could reduce lung injury. We could also reduce raw collagen production and lung inflammation. This is a PET study in a long-term mechanical ventilation study, and then the yellow areas, they are inflamed, and when we use the open lung approach, we could reduce inflammation. Not only in our group, but in Germany, also some investigators have shown very high inflammation when they used low PEEP. Pay attention that in all these studies, tidal volume was the same. And when they used a higher PEEP strategy, they could decrease inflammation. And finally, in patients in Boston, very recently, investigators have shown that there is an improved survival or inversely lower mortality when you use the open lung PEEP in super obese patients. This paper was published in Critical Care. And if you pay attention, also in the alveolar trial, there is a post hoc analysis showing a significant benefit when we select patients, obese patients. So my understanding is that the rationale is still valid. All the mammal species, they suffer from ventilator-induced lung injury, but the randomized trials cannot prove it because of some methodological problems. This is not too much to be depressed. If you remember, in the 20 years ago, only one study was showing the benefit of reducing tidal volume, and all the 3 other studies at the same time were showing increased mortality when we were reducing tidal volume. So it took us a long time to finally have a study that settled down the question, which was the ARDSNet. So some problems, the solution of some problems, old problems are self-evident, but the problem of PEEP is very complicated, and we need better tools. And my argument is that there are 4 details that are frequently overlooked. And we needed some good technology, for instance, electrical impedance tomography that can predict collapse at the bedside at the same time that we can predict overdistension and detect it very sensitively to understand some problems. So the devil is in the details. For instance, the reduction in driving pressure in the ART trial or any of these high PEEP trials was negligible. So only 1 or 2 centimeters of water. And we have recently shown in patients under anesthesia and with decubitus atelectasis that we can reduce a lot atelectasis, and we can reduce a lot driving pressure by 6 or more centimeters of water, just optimizing PEEP. And in some specific patients, especially when they were obese, we can reduce by 10 centimeters of water. Secondly, we have shown that many patients under volume control ventilation, they can breathe at 15 mL per kilogram. And this was happening in the ART trial. So we understand much better now that we have a better technology to monitor patients. And the ventilator does not tell us the whole story. So third, we have shown that some patients are very recruitable and other patients are not recruitable. And then we have now better tools to detect this at the bedside. This is a patient that can be very well recruited. This is an EIT display. And some patients, they are already recruited and we cannot detect any recruitment. So this patient should not be submitted to a high PEEP trial. And we understand much better about the muscles and a very frequent problem in the ICU. For instance, some patients, they reduce a lot tidal volume during paralysis because there is a sum of reduced inspiratory effort and expiratory effort. And this big expiratory effort that is bringing FRC to lower levels than during paralysis is denying the effect of PEEP. This is abdominal pressure and esophageal pressure after paralysis, and this problem is impairing the results of our PEEP trials. So, understanding these problems led us to do a new study in which we are randomized patients with only patients with COVID, because it's a very homogeneous population of patients. And then having these better tools, we are now carefully selecting PEEP for each patient, when it could be higher or lower. And using this approach, we are starting a new trial in which we are weaning the patients from mechanical ventilation and from oxygen a little bit earlier than using the conventional approach. So this is something that we will be exploring in the next few months. Thank you very much.
Thank you very much, Marcelo. We'll come back to you for some additional thoughts in a few minutes. But now it's my pleasure to introduce Dr. Luciano Gattinoni, who's a professor at the University in Göttingen, and is going to tell us why Marcelo was wrong, and there really is no hope for trials in the future. Luciano, please go ahead.
Okay, good morning to everybody, or good afternoon. So we are discussing if a need for trial for PEEP. My problem is, what is PEEP? PEEP is used for gas exchange, basically for oxygenation. Usually PCO2 goes up also, but for oxygenation, not much PEEP is usually sufficient. 7, 8, 10 centimeters of water may provide sufficient oxygenation. The problem of PEEP is the lung protection, open the lung. And this is back to Mead, to Lachman, to Amato. Open the lung and keep open, a beautiful title of marketing in editorial in intensive care medicine many, many years ago. Now, good. The recruitment for that should be kept open, the lung by PEEP, the amount of lung which collapse and decollapse is very different in mild, in moderate, or in severe RDS. Here, patient in ECMO, patient without ECMO. You can see that recruitment, the grams of recruitment may be dramatically different at the different airway pressure. And more important, even a 15 centimeter water, which is pretty high PEEP, clinically speaking, a part of the lung may gymnastic. This amount open up and close after a normal tidal volume when the PEEP is 15. If you want to keep the lung completely open, you need something, a PEEP usually around 20 or greater than 20. Greater than 20, I remind you, you are reaching in a normal lung, you are close to the total lung capacity. Try to take a deep breath to fully inflate your lung, and you feel as you should feel around 20 of PEEP. Now, we have here the 3 classical studies. The other study has already been presented by Marcelo, all negative. Here, lower PEEP, 10 versus 15, 8, 15, 9, 14. Mortality rate was absolutely indifferent. But, you know, when you look at this study, we say, well, wait a second, this is a general RDS. We put together every patient. We put together recruitable patient, unrecruitable patient. This does not make sense. We have to select better the patient. And Marcelo explained that if you take patient with good recruitability is much better, and maybe we will have some signs. However, I remind you that no signs were done in summing thousands of patients. So the need for trial, this is what in 2016, I prepare a big study for a PEEP trial in which I wanted to have only patients with the prerequisite, that means high edema recruitability, very high PEEP to keep open, that means even upper to greater than 20, and a number of patients sufficient to cover a wide range of PEEP, let's see, from 8 up to 22, 23. And I don't want the detail, but here you see a patient only with PF below 150, double stratification and randomization, a patient with 8, 11, 12, 15, 16, 19, 20, 23. So we were ready to go. But before to launch this study, I was waiting the results of the Brazilian study, so the ART study. And when the ART study, because year 2023, when the ART study, I had some doubt. And then we have experimental work, 4 years of experimental work in animals treated for more than 2 days with different PEEP, pressure, and so on. And then the COVID-19 pandemic. These are 3 reasons for which we aborted the trial, of course, not in 17 because of pandemic, but this is a good reason to see that the trial on IPEEP is useless, which does not mean that IPEEP is useless. Maybe useless, maybe useful, but in which patients? We don't need trial to understand that. And this is the ART trial. Now, my friend Marcelo tried to find the most strange reasons to justify the fact, a very simple fact, that the patient with very high PEEP and a tremendous recruitment maneuver die more, not all, but a fraction of more fragile patients do not support this kind of therapy. And remember, when the trial is so-called negative, we have thousands of explanations. But when a trial is positive, the signal is extremely powerful. Marcelo will say trial positive as an example, the ARMA trial, versus 3 trials we were negative. The trial when it's positive is positive. And this experimental work, here patients, now pigs, a lot of pigs, with the same driving pressure and increase in PEEP. Lower PEEP, the PEEP was 0, was 4, 7, 11, 14, 18, wide range of PEEP. And you say, oh my God, but these were normal animals. Of course, the normal animals are the better model to study VILI, because the only lesion that you can induce are due to the mechanical ventilation, not for anything else. And what's happened in these animals? Increasing PEEP above 8 in these pigs, you have a sort of dual response. Vascular congestion, inflammatory, with PEEP of 4, between 4 and 7, we had advantages of PEEP. But increasing PEEP, we have disadvantages. So we have a sort of U-shaped, the same for atelectasis and alveolar collapse. The problem is to identify the right number of PEEP. Higher and lower PEEP does not mean anything, are just a nice cover for our ignorance. And these are same mechanical power. That means we have a patient with PEEPs with 40 of frequency and PEEP low, patient with high PEEP, patient with high tidal volume, PEEPs with high tidal volume, all at the same amount of energy. And mechanical power, wet to dry, lung weight were similar. But the PEEP was much worse, the patient in which the same mechanical power due to the high PEEP had a double weight, a lot of hemodynamic problem. I mean, the lung is very resistant to injury. What is crucial and is always or very often forget is the part of hemodynamic and the price we pay to maintain the hemodynamics. We are able to maintain the hemodynamics, but a very high price. And at the end, an homogeneous disease, which we may call RDS. This is bilateral pneumonia. This PO2 FiO2 look in this patient, 95. This same patient, days after, 84. So the same PO2 FiO2. Now, would you use in these patients 20 of PEEP as it come out from PF table, from Love Express trial system, from the French system, or would use when it's full of gas? Then you may discuss COVID is this RDS, not RDS. Is absolutely an unuseful concept. You have to use the basic physiology. When the lung is full of gas, PEEP is not recommended. In these patients, the driving pressure was always below 10, 9, 10, 11. Okay? So when you compare PEEP, higher and lower PEEP, we compare the risk and benefits of athlete trauma. With high PEEP, we avoid athlete trauma. With low PEEP, we avoid volutrauma. We decrease in both cases. And what's happened? That we have a different sequence, the gas exchange, the inflammation edema, and so on. But the results is that in all the trials we did, between 9 and 15, the athlete trauma or volutrauma have equal benefit and damage. When you go at higher PEEP, with as in the art study, the volutrauma wins. That means the risks are far higher. So if you say, okay, but now we have a trial and we need a very homogeneous patient, okay, take a patient recruitable, but within the recruitable patient, recruitable from pneumonia or recruitable for sepsis. And then you decrease the group, and you end with the true medicine, which is the attention to the care of the single patient. I'm wondering if it's not the time to cancel the name ARDS, as a Petty suggests, an inventor of ARDS. Thank you for the attention.
Thank you very much, Luciano. Lots of common points there. And I think one important distinction to think about is whether we're arguing about the benefit of higher versus lower PEEP versus the benefit of doing trials of higher or better or low PEEP. So I'll ask Marcelo to respond in 1 minute. Any thoughts on Luciano's presentation? And then, but I want to leave a little bit of time for questions because I have some for both of you.
Okay. I would like to come back to this slide in which we are doing this new trial only with COVID patients, just because it's what we have in São Paulo, but I think I could do the same thing for ARDS. So on the left, we have the PEEP levels selected by the ARDSNet table. And then on the right, we have what was chosen based on EIT, in which we are trying to avoid atelectasis caused by decubitus and at the same time overdistension. So trying to avoid the problems that Luciano showed when he applied too much PEEP in the animals. So we are trying to find the right spot, the sweet spot. And in average, these people, the selected PEEP based on individual characteristics of the patient was higher in average of 15 against an average of 12 here. And then using, so I have to agree with Luciano that we should stop saying that we need high versus low PEEP trial, despite the fact that when we do individual PEEP titration, the end result is a little bit higher PEEP than selected by tables. And but I still believe that the rationale the basic rationale of this individual PEEP is the same. We would like to keep a very reasonable amount of open lung. Otherwise, you have too much atelectasis, too much shunt, and a very high driving pressure. So the old rationale is still the same. And let me just show you this post hoc analysis of the ART trial, in which we are trying to understand what happens with the mortality of patients when you look at the driving pressure after randomization, which means that I had, let's say, 10 of driving pressure at randomization, and then 24 hours later, using the treatment, I'm having 15 of driving pressure. So those patients in which driving pressure increased are precisely the ones in which mortality increased. So it's above 1, the risk of death. And these are the patients causing increased mortality in this trial. And this is exactly what we should avoid. And this is why I believe that individualization of PEEP is now the next step. And this is going to lead us a little bit higher than we have been using, but is still going to be an individual PEEP based on patient physiology. Thank you very much.
Thank you, Marcelo. Back to you, Luciano. Anything further you want to respond?
Well, I'm agree that the individual PEEP is exactly the contrary of the big trial on PEEP, and I agree with Marcelo. Exactly my point. By the COVID, I have to say one thing, that we are just analyzing a few patients in which we had supine position at 5, prone position at 5, and supine position at 35, because the risk of pneumothorax in this COVID, okay? So in this patient, we could estimate or measure the consolidated tissue, that means which does not open at pressure greater than 30, at pressure of 35, we call consolidated, and the atelectatic tissue, the patient with the pressure lower than, which open up at the pressure of 35. And it's very interesting because you see that the atelectasis, the atelectatic tissue, decreased tremendously with time. So it's very strongly associated with time of observation. Greater the time is greater the consolidation versus atelectasis. When the ratio between atelectasis and consolidation decreases, when you increase the pressure, the compliance decreases. The other one, the compliance increase. So how can you organize a trial with this? You have just to use the principle of protective strategy, which has lower to minimize alveolar stress and strain, but forget the guideline derived from the big trials. From the big trials are applied to a wrong population in or to mixed population to make sense. You are not taking care of population but the patient. And I think COVID is a tremendous example of that. In Lombardia, they start the first months, the people was around 16, 17. After 1 month, the average P was around 8. That means something.
Thank you, Luciano. I think actually we're arguing a lot for the same principles as often happens in these debates. I think everyone would agree that the individualization of PEEP is key. And I think you've both highlighted some challenges if we, and maybe even some debate about philosophically whether we need to prove that is a better approach with a trial compared to just letting physicians run amok and do as they will. In the last couple of minutes, I wondered if I could ask, what about the interaction? PEEP is obviously not an isolated treatment, and we often we have tested it in conjunction with recruitment maneuvers, and in some cases we've tested it in conjunction with prone positioning. And do we need to consider those two factors, both in our clinical practice and in our trial design as we think about PEEP?
Good point, Neil. This principle of individualization is very nice, but is very cumbersome because it means that you have to be at the bedside watching the patient all the time. And going to your point, for instance, we have observed that two interesting factors in these COVID patients. First is that patients in which you don't individualize PEEP, you lose the benefits of prone. So we have seen patients in which you prone, and it's a good strategy to recruit atelectatic tissue on the dorsal zones. But once you go back to supine, you lose everything if you don't apply enough PEEP based on some method that should not be blood gas only. And the second point is that the same principles you can apply for recruiting maneuvers. You can make it completely wasteful procedure if you don't apply enough PEEP. And then going along with these statements, it means that you have to individualize PEEP every day. And then this is in agreement with what Luciano is talking about, the difference between long-term atelectasis and short-term.
One of the reasons I like this debate about clinical trials in PEEP is because it makes us think about how we would actually generalize this strategy of individualization away from an expert center. So, how do we make this happen without having Luciano Gattinoni or M.Amato at the bedside tweaking the ventilator? Is there a way that we can, I don't want to say cookbook it, but make it more generalizable and easier for your average clinician to understand what is the right PEEP?
I'm afraid to say
no easy answer to that one.
No, this. I mean, this is an old question, no? And is the tendency that we have now. We use a protocol to simplify, to spend money, to have less people, and so on. But that does not mean to make good medicine. That's it. If you have to accept that you decrease the quality of medicine. It depends at which degree of decrease you may accept. But you cannot pretend to have a perfect medicine or the best you can offer if you don't have to pay a price. You cannot have a very simple magic pill that gives you the miracle of a perfect individualization of PEEP, hemodynamic, blah, blah, blah. It's simply impossible. That's it.
Well, that might be a good philosophical point for us to wrap up, as I think our time is up. It's individualize PEEP or not. Be a good doctor and pay attention to what's happening with the ventilator and the patient. With that, I'd like to thank both of our speakers for a lively discussion, and thanks to you for listening.